inside out meniscus repair. Are you able to see the
No,
external picture?
Right now we can't see the video picture.
External picture and
Everything-
arthroscopy picture.
No, none. No, neither external picture nor the arthroscopy picture.
Can you tell me once you are able to see it? I will demonstrate it.
Yes. In the meantime, you can tell us what is your plan. Yes, now we can see the inside picture and outside picture also.
Okay, fine.
Yeah.
So
Perfect.
we have this patient who has a little arthritic knee. He got a varus deformity also. Yeah. So I put an anterolateral portal, anteromedial portal. And through the anterolateral portal, I put a camera in. And you're able to see the anterior part of the medial meniscus with some arthritis there. And some medial part of the meniscus is also seen. This is medial side, okay? Medial meniscus we are seeing. A lot of arthritic changes with loss of meniscal tissue. So we are going to demonstrate inside out meniscus repair in a medial meniscus. Okay, yeah. I feel this is a very good technique for a lot of bucket handle tear, especially for horizontal cleavage tear with parameniscal cyst. Very nice technique for that one. And it's cost effective also. Okay. Let me just show some instruments first, because one has to be familiar with instruments for doing inside out repair. Are you able to, can you focus camera here for me? Over here. So we have some instruments here. Are you able to see the instruments?
Yes.
So this is zone specific navigator. And we have several types of needle available with curvatures on the tip.
Picture, big view.
Outside picture, make it larger. Outside picture.
Outside picture, please.
Yes.
So can you see there is a little knob here?
Yes, now we can see.
With this knob, we can actually try to fix this needle in any angle that we want. As you can you see that?
Yes, sir. Yes, sir. Nice.
This actually shows that you can do access 360 degree. So whichever way you want, you can fix it. Okay. So this is for posterior horn and middle area of the meniscus. And there is one more which has got a very high angulation. This is especially for anterior horn. Anterior horn of either lateral meniscus or medial meniscus, you can use that. Okay. So this also can be turned 360 degree as you like and fix it. And then there is a small switch here. This will try to advance the needle as you like. Each time we are advancing 1 centimeter. Okay, 1 centimeter of needle will go in. Okay. So where is the needle? So the device is needles in that. It's a long needle, two long needle with fiber tape, small fiber tape attached to that. You see that? So hold this one.
Yes, sir.
So we can actually put this needle through this hole, and with this we can keep passing 1 centimeter, 1 centimeter, 1 centimeter, and it will come out here.
All right.
If we pull the whole needle out, the fiber tape will come out. Okay. After passing one, we'll have to pass another one like this. So we'll have a loop inside the joint, and externally we will have to tie with a knot. So that is a principle. The same principle can be applied for.
Sir, when you're pushing the knob forward, the needle goes in. Can you reverse it also, sir? Pull it back.
You can reverse it. So now I passed it in. I can also come back. It will go out. Can you see it is going back?
Yes, sir.
Okay. Thank you, sir.
So if you have passed too far, then you can actually reverse it and bring it back. And you can adjust the angles to the way that you like. Okay. It's a very sharp needle.
Yes.
Okay. And it can pierce the tissue quite nicely. So that is one aspect. Next aspect is the thing that worries me in inside out meniscus repair is damaging structures. Okay. If it is a medial side, I'm worried about the saphenous nerve. And if you are going too posterior, which usually we don't employ this technique for a high posterior horn medial meniscus because of fear of the vessels and main vessels and nerves, we employ it for the posterior medial aspect, not for the total posterior aspect. Okay. So for that, what you do is normally hold this one. I make an incision here. Can you see the incision here?
Yes, sir.
Show me the forceps. Give me the forceps and one scissors.
Subramanian sir, what are the landmark for your incision?
I'll
This
show you.
safety incision.
So I've made a marking of adductor tubercle here. That is adductor tubercle. Okay. Can you see that?
Yes,
That's
we can
adductor
see.
tubercle. Okay. Yeah. Here is the anterior part of tibia. Posterior part of tibia is here. Hmm? So make a line between adductor tubercle and posterior part of tibia. We don't have to go through the whole line, but that is the rough landmark for you. And joint line is here. That's the joint line. Okay, make an incision about 2 to 3 centimeter, which I already made for you. Okay. And then this is the sartorius fascia. What I see? This is sartorius fascia. Okay, can you see the sartorius fascia?
Yes.
Here is the sartorius fascia. Okay. Now, once you are in the sartorius fascia, do blunt dissection like this, then you can see the posterior medial part of the capsule. This is posterior medial part of capsule.
Yes,
sir.
And semi-membranosus is on this side. Semi-membranous is on this side, and the medial head of gastrocnemius is here. So this is what I am showing is a capsule only. Okay. This is a capsule, posterior medial capsule. So saphenous nerve, which is worry for us, isn't it always? From adductor tubercle, at least about 5 centimeters away. So saphenous nerve course will be somewhere here. Somewhere here, okay? Yeah. So
Okay, sir.
from posterior tibial joint line or adductor tubercle about 4 to 5 centimeter posteriorly, we will see the saphenous nerve. We're not going to go there at all. Some people have a habit of dissecting that. I think when you're doing a mini invasive, you don't need to do that. If you are able to come bring your suture material over this area around the posterior medial capsule, almost you are safe. You don't need to go there at all. But be aware, saphenous nerve is about, make a drawing for saphenous nerve where it is, so that you are aware the needle does not go there. Okay, yeah. So let's now demonstrate one suture application. Okay, we have only 3 suture materials available right now. I already done one just for, let's open the water now. So I have Vishal helping me here. Normally we will be able to do some valgus stress and do some pie crushing also. It will help us for getting medial exposure. Yeah, we can use zone navigator. But here, I mean, is a little arthritic knee, so doing medial pie crushing is not possible. Okay, yeah. So now, anterolateral portal. Are you able to see the
Yes, sir. Yes, sir.
picture?
Yeah. Zoom out, outside image, zoom out a little bit.
Okay, let's see.
Yeah, thank you. Thank you.
Let me just, there is some bubble there.
Yes, some debris are there inside
Increase-
the knee joint.
Give the shaver for me. Let's just do some. There are some good points and bad points about doing in Cadaver. Okay. Only good point is probably that also we have like.
Whatever you want to demonstrate, you can demonstrate. But sometimes your life surgery don't get that particular case.
Yes,
That
yes.
is the advantage. Yeah. So Subramaniam sir, sometimes you have ACL with meniscus repair. So how do you proceed with your sequence? First, you complete your ACL tunnel.
Usually, when you're
then
doing ACL and meniscus, I try to put a ACL femoral tunnel, okay, and keep the meniscus ready. And meniscus, I do repair once the femoral tunnel is done, okay. So I have some marrow. Let's go. Give that zone navigator to me. So now you can see that. Can you see the zone navigator here?
Yes, sir. Yeah, yeah, yeah.
This one you already loaded the needle, but you have not passed through the tip. You just loaded it. So I'm passing it through the anteromedial portal. It's going in here. So I'm going to do another stitch over in the middle part of the medial meniscus. Okay. So I've just kept it here. Now pass. I'm going to pass the needle. You can pass the needle. Okay, like this. So can you pass the needle for me? Just keep pushing it. Because you have to keep on the place where you want to pass. See, can the needle is coming out? Can you see that?
Yes, sir.
Can you see the needle is coming out? Okay, yeah. Keep passing. Okay, now 1 minute. So now the needle has come out through the skin here. Okay. Hold the scope for me. So now what you have to do is have gone too far in, you can bring it out.
Do you use something like a spoon, right angle spoon, to deflect the needle?
I think definitely
You
we
can
have to
see.
use some instrument
Yeah,
to keep our side not
you can deflect the needle towards your incision,
leave
the
it.
posteromedial incision.
And see the needle is coming back.
Yeah.
Okay, now
outside
keep-
outside image.
outside picture we have to see. So keep seeing
Outside
there.
image,
Are you able to see the
make it
outside
big.
picture now?
Outside image, make it no, the other image, the knee image. Outside
No.
camera
Are you
2.
able to see the knee end?
No, sir. Outside cam.
Wait,
Yes,
1 minute.
yes.
We'll just.
Yes, sir. Yes,
So
sir. I can see.
now, so we have kept a Langenberg retractor here. Can you see that?
Yes, sir. Yes, sir. Nicely.
So if you having some instrument over there, it makes our mind safer that we are not going on any big structures over there. Okay, yeah. So people use spoon. Some people have their own. They have a mopping pad or something to pull it because these needle can be very sharp. Don't pull it with a hand. Okay, it can cut your hand. So now we have done that. Okay, so this is one done. Okay. I just get the
Spoon is
other one
the
focused for you. So
spoon
one
is
is
the
come out
cheapest
through
device.
here. This is one set, we already done it. Okay, this is the next one, we are doing it. So just show the relax now. Come over here.
So you can put your vertical or horizontal mattress, whatever suture you want.
Yeah, correct.
Navigating
So,
your.
yes. Now I'm going to readjust my area where I'm going to put.
Inside
Okay.
image.
If it
Inside
is
image.
a tear which is like a vertical longitudinal tear, I'll put one here. Okay. If it is a tear which is a cleavage tear, I'll put here. Okay. Next one. If you want to put a mattress stitch, then I'll put here. So you can change your configuration as you like. So now we are going to put one underneath the meniscus like this. Okay. Yeah.
Yes.
Okay. Now pass the needle again. Come. 1 minute. Keep watching there. So now are you able to see the skin external camera there?
Camera 2, big
Camera
view.
2, please. So that
Yes, thank you.
you keep passing. Yeah.
Yes, sir.
So
You can
again,
see
it's
the
coming
needle
back.
coming.
Okay, over
Yes.
here. So keep pushing it in. So inside out is actually a fairly simple technique, which is also cost effective also. Yeah. And this is for the medial side. You are going in between the behind the posterior capsule. Okay, thank you. I have a artery clip and pull it. In the lateral side, you have to be careful about the peroneal nerve. So you have to make sure your incision is in the right place. So now keep pulling it, pulling it, pull it, pull it, pull it. Can you see this? See the arthroscopy picture there?
Yes.
Yes.
Okay. So this is ideal suture pattern for if there is a cleavage tear like this, okay, where the parameniscal cyst or something, then you can close that cleavage like this with the help of one going above on the superior leaf of the meniscus and then below the inferior leaf of the meniscus and try to bring the suture material outside through the membrane here. And now we have this, hold the scope for me. So can you see this here?
Yes,
There's
sir.
no
Yes, sir.
soft tissue in between. There's only the posterior capsule is there. Are you able to show the external picture for me?
Yes, sir. Yes, sir.
Yes.
Nicely seen.
So
Nicely seen.
this is one of them. This is another one which I already done it. Okay, before. Okay, so by putting knot here, I'm pretty sure there is no soft tissue. Okay, so this is one way of doing it. In the lateral side, so you have one more, but lateral side is very difficult to go now because we have not prepared the lateral side. If you want to go for the lateral side, we'll go for it. At least I can show the dissection on the lateral side if you want to. Or your how is the time getting on there?
I think.
Dr. Sharath.
Show me. Hold.
Oh, lateral already.
Sir, lateral there is a different demonstration, sir.
Lateral side,
Yeah,
dissection.
Yes, sir. Yes, sir.
Okay. I'll
You
show the
just show, sir.
dissection demonstration, okay?
Yeah.
So, and now we are just going to put knot in between these two. The knot is just you put a as usual knot, okay, and hold it there and tighten it. Then you can see that I'll just put knot of one of them and then we'll go there. Cut this for me.
Sir, Sunny is, I think, showing a lateral demonstration. So,
I'll just show how the lateral dissection is, okay? Because the worry for me in all these inside meniscus repair is trapping the tissues in between. That has to be cleared. And you usually make about 3 centimeter incision, 2 to 3 centimeter incision are comfortable. You are not on the nerve and all. So hold a knot for me. So inside out repair is actually almost we can call it as gold standard only. Because I think Jagadish also told earlier it's a gold standard. Because before inside out came, all inside came in, we did only inside out for a lot of patients. Cut this one. Come.
cost effective also. Very much cost effective.
Very cost effective because
You have a
with
circumcision stitch also.
with the cost of one all in, you can actually do multiple here. Fiber tape is not cutting. Okay. Okay, cut this needle also. Okay. Lateral side, the worry is peroneal nerve, isn't it? For all of us. Okay. Hold the knot. It is cutting through. That is because that is the. Okay, thank you. Okay, fine. So that is done. I just show the lateral side now. Okay. So can you somebody show the camera to the lateral side here? It'll come here. So give me the marking pen. I have a gauze piece or something. So come to this side. Camera should focus this. Close.
Yeah.
So lateral
Subramaniam
side, the
sir.
landmarks are first is head of fibula
Subramaniam
is
sir.
here.
Subramaniam sir, Sharath has told we are already late, so we will go for root repair, and then later on we will go for laterally. Yeah. So Shreyash is there.
No. Okay. What I'll do is I'll do the dissection and keep it ready. You can just come for 2 minutes and then come.
Yes.
Go back.
That we can do, sir. So we will shift for root
Okay.
repair now.
I'll do the dissection here and show it to you with the all pictures on. Okay. Yeah. Fine. Give me a. Has another marker pen because this marker. You are going to go in this one.
Cameraman.
Okay. We have only one.
Oh, one
So
cadaver
in that
only.
case.
Next, I think there is a separate station for.
Okay, I'll just demonstrate it like this only, okay? Because the problem is we have one cadaver. In that only root repair is going to be done, okay? So here is the head of fibula. That is the IT band. So we have to go and the biceps tendon is here. Where incision is going to be between that IT band and Gerdy's tubercle, which is over there, okay? And go in between IT band and biceps. And once you are in that layer, try to identify the lateral head of gastrocnemius and the posterolateral capsule. Peroneal nerve is far placed over this area. So as long as you are in this region, we make about 4 centimeter incision there, you are safe from peroneal nerve. No issues will be there. And each time the needle comes, try to make sure you keep a spoon or retractor over there and try to bring the needle out through that. So that is a brief demo for the lateral side. But peroneal nerve is here, far posterior, and don't go there at all. So because the incision is going to be over this joint line, IT band, and Gerdy's tubercle. Okay.
Yeah. So I think we will shift for root repair technique by Dr. Shreyas Gajjar. Cameraman.
Thank you, Subramania sir.
Thank you, Sharath, and thank you whole lab
Thank you,
team
sir,
here.
for excellent demonstration. Thank you, sir.
Thank you.
We'll now go ahead with the demonstration of meniscal root repair by Dr. Shreyas Gajjar.
Can we hold this, please? Yes.
The suction का डालो please. Oh, it's going to be challenging immediately. Sure, needle.
Shreya sir, can you hear us, sir?
Yeah, Bhupesh, just give me a minute. I'm just
Yeah.
trying to see if I will be able to demonstrate or not, because as Subra mentioned, it is a arthritic knee.
Yeah.
So I just need to clear to see. Just give me straight the root repair first. So we have done the pie crusting to increase the space, the working space, but this is, I think, the maximum we are able to succeed, but it is reasonable enough. So first thing, so you imagine that there is a root tear at the back. What we are going to do now is make the tibial tunnel. So can I have the jig, please? So
Shreyash,
do we have both arthroscopy and the outside image?
Shreyash, can
Yeah.
you show the steps of pie crusting for benefit of delegates?
Okay. So needle, please, Venflon.
And at what point you do? What is your magic point?
So, you switch the OT lights off, there is a illumination. The other way is to just press on the outside and see where that area is. And then you just come in with the needle. So generally, I stick to the mid substance and the femoral side, and more in the posterior half of the MCL.
And what
And
needle you choose for pie crusting? What size needle?
16. The same I use for my outside in portals for a knee arthroscopy or shoulder. So I'm just making multiple through the same entry point on the skin. I'm going in different directions superiorly and in the mid substance to try and do these multiple drill holes. And then my assistant is actually applying a valgus stress to see how much it opens up. So this is reasonable enough. And what we need to see is if our instrument is going in well. But obviously, in real life situation, you will have a little more opening. But I'm able to negotiate. So, earlier in the question was about the Gilchrist maneuver. So, you go in from here, and you see that that's the ramp area, and that looks fine. So let's stick to the route right now in the interest of time. So we have a jig. I don't know. Do you have the outside image?
Yes.
Yeah.
We can see both the.
Yeah, so this is a second generation root repair jig. We already have a third generation, but basically there are markings, so you can decide where your entry point on the tibial joint side is going to be. So it is a low profile jig. It has a curvature to accommodate the contour of the femoral condyle. So we are just going to इसको पकड़ो आप. Yeah. Can I get you on this side, because it will be easier to hold the camera? Somebody to hold the camera, yeah. So we are just negotiating the jig to the back of the tibia. And there's 5, 7.5 and 10 millimeter markings on this. So you have to hook this in the back. Fluid is going in. Yeah, good. So we just got to hook it to the back of the tibia like so. And then
First
on
you,
the
Shreyash, first you make your tunnel, then you take bite from the root.
yeah, because I
Yeah,
don't
all
want
right.
my sutures to come in the way.
All
I
right.
always do my bites later. I just, so that the suture management becomes easier. So I'm just trying to get a good view. Suction karo re Rohit beech mein, so I can just see what is happening.
So what are your landmark for your tunnel?
So I'm
tibial
just
tunnel?
hooking onto the posterior margin of the tibia, as you can see here.
Yes.
Do you have a view? You can appreciate.
Yeah, we can
that?
see both inside
Okay.
and outside.
So I'm going to go at the 5 millimeter mark. So can we hold the camera, please? On the outside, you make a percutaneous. So the sleeve of this root repair jig, you can just feel it on the tibia. Try and stick towards the midline, because you're coming posteriorly, just like the PCL. You're coming closer to the midline. So we do that.
So this 5 millimeter is posterior to the posterior joint line. This marking is for
Anterior to the posterior joint.
anterior to the posterior joint line. Oh, that
Yeah.
is.
So I'm just making a percutaneous incision on the tibia. I don't, you have the outside view?
Yeah.
Okay, good. So then we are passing the dedicated sleeve and locking it. I'm just making sure that the jig has not moved. We are sticking to the midline. Yeah, okay. We'll take the camera back a little. Great. The locker of 5 locked, you know? Okay, good. So we have the sleeve now. So I make a socket rather than a tunnel, just a centimeter on the tibial side to minimize the potential concerns with bungee effect if you make a tunnel. So I've just hooked it here, and you have a good view. So what I'm going to do is I'm going to pass a beth pin to make sure that my entry point on the tibia is way posterior where I want it to be. So I can always kind of revise it. So pakado, please.
You try to put your root tunnel centrally.
Yes.
Yeah.
I'm just trying
And
to focus the camera. If you have a good view, yeah, that's good enough.
at
And
what
then-
angle you have set your jig?
So so here it says 70, but I will, it's somewhere between 65 and 70, Piche le lo, please. Good. So we can see that. Yeah. Again, it's, yeah. Drill, please, the wire. So we are passing the wire now. One of the important thing is to lift the jig and go as posterior as possible. And go slowly in real life situation. There you go. So that's my entry point. Jig ko pakdo, please. Yeah, very good. So we're just going to make, you can use a shaver also to make sure you're happy with the entry point. I'm just going to double check. So this is good point, Rajiv. It's right
Yes.
at the back and towards the midline. It's not laterally onto the posterior body of the meniscus. So I'm happy with this. Please hold this. So once I commit to this entry point, then I'm going to use the flip cutter straight away. So if you have the outside image, so you need a longer flip cutter because you're going at the posterior part, not in the anterior. So we have a long flip cutter. And I've taken the smallest, which is 6.5, because I don't want to make a bigger socket. I just need something to allow my sutures to pass through. So we are just loading the flip cutter on the drill. You can see it outside. It's got these markings and it's got a grommet at the end. So I'm just going to go now and very slowly.
So what is the length of this
Suction
flip cutter, Shreyash? This is a
length.
long flip cutter, I think.
Yeah, it is a long.
Yeah, longer. This is for
20,
root.
I think 25, yeah.
Yeah.
So you just keep this, Rajiv, and you can reuse it a couple of times,
Yeah.
Because 6.5 will generally be used only for root. You won't use it for ACL unless you're dealing with a child or a small.
Yeah.
So I think I can feel that I'm hitting the thing. Very good.
So what will be your tunnel size with this flip cutter?
6.5. The size is 1 centimeter.
Yeah.
The
So
length.
it's
The
a
length you mean?
Yeah.
You mean the length?
Length.
Yeah, okay. 1 second. Focus. Okay, good. So just checking. One. Hold it, please.
Yes, we can see. I think indirect sign is the fat globules. If it comes, that yes,
Correct.
it appears that is the best indirect sign of
Yeah.
you have drilled the second cortex.
Yeah. Just trying to get the camera, angle. Okay. Yeah. So what has happened is, while I feel that my entry point is a little anterior, because the jig kind of moved. Okay. So we are going to we have to demonstrate the steps here. So that is important. So just hold the thing. We are going to unload the jig now, offload rather.
Yes.
And take it off the sleeve. Yeah, great. Yeah. And I need a shaver next. So just camera, can you remove? Yeah, very good. Fantastic. So we're just taking it off. We have left the sleeve there. Just can I have the shaver, please? Shaver de do. So I'm just going to see the. Okay. Focus. Yeah. Okay. So can we hold the camera now, please?
Yeah.
Yeah. So it's at the same entry point. That's good. Can we have the suction so we can see it? Yeah. 1 second. Just please hold this, Rohit. We keep the light lead. Yeah. So that's good. So I'm happy with that.
Yeah.
That's so what I'm going to do is just go a little bit more, advance it, and hammer, please. So we have to fix the sleeve onto the tibia. That there is a step so that if somebody is creating a socket, long socket, it does not become a tunnel. So we are just going to hammer it, engage it in the bone. You have the outside image, right?
Yes, yes.
Okay, good. So that's it. So now I'm going to advance the flip cutter. Suction, please. Thoda lightly chalu hi rakho so we can see what we are doing. Okay. So it's gone in. Dikh nahi raha hai. Can we have the shaver dalo na, please? So we can see what we are doing. Yeah, that's better. Okay, perfect. I want this view if possible. So we are going to now deploy the flip cutter like so. Okay. Can you see that it's deployed?
Yes,
Yeah.
yes.
Okay,
Just,
good. Anytime the vision is not clear, please let me know, huh? Because I'm just
I think central LED skin is not.
central LED screen.
AV guy, yeah, LED skin. It's coming in at the level of your jig only.
Okay, now it's okay. Acha, in the auditorium thing. Okay.
Yeah, now
so
it's okay. Yeah, just
good. So I'm
zoom
now
zoom in
creating.
and show how you open the flip and how you close the flip. Yes,
Okay, okay. So
just
yeah.
zoom in because
So, yeah.
everyone can see. Cameraman zoom in.
Yeah. 1 second. One
Yes.
second. So yeah. So that is the essay pakado, please. Please hold it like this.
But
So
this
it's
is
not
most
deployed
important
yet.
step.
I'm just going to turn it around. So it's not deployed. There is a
Yes.
button on the outside and I pull it towards me. You can see it now deployed.
Yes, yes. Fantastic.
Okay. Now I'm going to just come down to the plateau of the tibia. And then I'm going to use this
Inside.
grommet. You have the outside image?
Inside view, please. Inside. Cameraman
Inside is,
inside view.
yeah,
Now we
inside.
can see it.
Yeah, and outside, you have the outside view?
Yeah, outside view. Can you
So
clean it? I think
Yeah.
some debris is there.
Yeah, we'll clean the
You can clean
inside.
it.
Just 1 second. Just hold
Yeah.
suction.
So
Chalu
that,
thi.
yes. Excellent.
1 second. Shaver de do. Yeah, it just clears in a few minutes. 1 second.
Yeah.
Valgus rakho na. Yeah, 1 second. Yeah, that's fine. I can't see the screen now. No, I can't see. No, I can't see. Yeah. 1 second. Hold this, please. Okay. Yeah, better?
Yes, we can.
Okay. Just hold the camera, please, now. That's fine. So I just want to make sure I have deployed the flip cutter, which I have.
Yes.
Now I'm just going to go a centimeter, okay, inside. So on the outside, there's a laser mark. So I've gone a centimeter. That is all I need. Then I'm going in again. Obviously, we want to do it under vision. We want to make sure that, yeah. So that's it. So now I'll close the flip cutter. Can you see, Rajiv? We have done that.
Yes.
And now I'm just withdrawing it because the purpose of the flip cutter is served. Okay. Now shaver, please. Yellow, please. Thank you.
You have a good raw area with 1 centimeter depth. So
Yeah.
meniscus will land there.
Yes, shaver. इसको छोड़ दो please, कुछ नहीं
And this
करना।
is very important. If you don't create that raw area, there will be no healing. It's a soft tissue to bone healing. So there should not be any cartilage there. The whole of the meniscus should sit inside the raw area. And that is the advantage of this flip cutter.
So we are just cleaning the mouth. 1 second. ये और पकड़ो। So we are cleaning the mouth of the socket here. Okay, so that's curate also. We can use a curate.
Shreyash, you prefer single tunnel or two tunnel, double tunnel
single,
technique?
single,
Single
single.
tunnel, yeah.
So I have cleared the mouth of the socket as you can see here. Okay. To allow that root to heal to this
Yes.
part of the bone. Shiver, please. Okay, now we are going to put a cannula for suture management. So passport cannula, artery first. Make sure that the portal is big enough. Somebody, good. So for suture management, I think a cannula is good. Knife. Make a bigger portal because we are putting a cannula. Okay. We have dedicated passport inserter as well. Okay. Yeah. And Prokar, please.
Yeah, yes.
Making
So you
sure
can
that
see the advantage of passport cannula. So it gets locked inside also, and whenever you are passing a suture, the soft tissue will not get trapped in between your
hair को
suture
इस तरफ
material.
लेना है, बहुत
It's always
important
better
है।
to put a
Good.
cannula before you are passing any suture.
You can come on this side now to help me. That will be great. Passport cannula pakado. Good. So we are ready with the scorpion, and I prefer the cinch configuration. So you have the outside image.
Yeah.
So one way to achieve a cinch is to preload the loop onto the shaft of the knee scorpion. Can you see
Yeah.
that? Is it
Suresh,
visible?
for benefit of audience, I think just show how to load the needle and
Okay.
how to load the suture, because I
Okay.
think they can see.
Yeah.
Yeah, just
Uh,
zoom
Okay. You have
outside
the
camera, zoom in. Yeah, Suresh.
So try and yeah, you can see it, right?
How to
I'll put
load.
it under
Yeah.
the blue background. So because it's a
Yes.
white suture, is it better against the brown or you can see it?
Yes, we can see.
Okay.
Yeah.
So don't waste the suture. Just go very close to the edge. Then you just feed it through the needle, and you can use the posterior shaft to just prime the needle.
Yes. All
Then,
the check
then
outside.
you can use it for the bite.
Yeah.
Make sure that it is sitting right in the slot, and then you go in. Yeah, the loop. We'll take the loop, cinch loop. Hope the cannula, please, Rohit. Cannula. So one way is that you can preload the loop on the shaft. So you can see that cinch loop is being preloaded. Can you see it?
Yes.
Yeah? Okay.
So this is a very good self-retrieving suture passing device, the Scorpion, and it works very well in very small space also. You can see.
Cannula. Okay. Can you put another one? So the first cinch suture is passed. Okay. What I tend to do is can I have the fiber stick, please? So I tend to just deliver this through the socket. So again, it does not come in the way, or you can pass it outside the cannula. So what I'm doing here is, have you got the outside view?
Yeah.
So I'm using a fiber stick and getting my shuttle suture. Can I have the grasper? Suture retriever.
Yeah. So once you pull out, it will come down. Yes.
Hold this, please. Good. Hold it, don't let go.
So now you are pulling the suture.
Yeah.
Yeah.
So now I'm going to railroad. Can you put it in that? Can you have the outside image?
Yeah, it's there.
Yeah. So
Just
I'm
zoom in. Just
zoom
zoom
karo
in.
idhar.
So the yeah. Yes.
Hold
Now we
karo.
can see.
Hold.
Can see
Yeah.
the railroading.
Yeah.
Yes. And just he will pass it through. Yes. And you see how it.
We'll need it again. Can we load this fiber stick again, please? So
Yes.
that's, that's
You can see.
how it's going to be.
First bite.
Yeah. Now we're going to take the second one. Can I have the knee scorpion? So again, it's loaded.
So how much distance you keep in between two bite?
Half a centimeter.
Oh.
Depends on the quality of the tissue
Quality.
also.
Yes.
You should get the, but you want to come closer to the midline, not go away.
Yes.
So again, cannula, good. Yeah. Yeah, good.
Single tunnel, two sutures.
Yeah.
Yes.
So we are just passing the second one, the cinch. So that's it. Now we'll again pass it down to the tibia. Water. Yeah, we were just running out of water. Okay, good. So we'll pass the fiber stick through the sleeve into the joint. Okay, retriever. It's best to have different colors. Today we have a white color only, but two different colors would help in identifying easily, so you don't miss out. Okay, karo please. Barabar tha, don't touch. Yeah, okay. No, pull the fiber stick out. Okay. Lelo, please, somebody. Thank you.
Cameraman, just zoom in there. Yes.
Then now we are passing the second
Yes.
suture. Hold it. Hold it on. That's it. Not so much. Just a little bit. Yeah.
Yes.
And you're going to just deliver it, as you can see here. Okay, done. The suture retriever can also go. Good. So we've got the two cinch out. What I'll do is, one second, let me see where it is. Yeah, give me a probe, please.
So tibial side, what is your fixation method?
I
How
use
do
an
you
anchor. Earlier I used
anchor?
to use a disc.
All
Now I
right.
use an anchor. Suture chodo, tight nahi karna hai.
So sometimes there is overlap also. So see with the probe, he is trying to.
Yeah, I'm just trying to kind of reduce the
reduce the root towards the crater,
Yeah.
and then he will pull it out and fix it over the tibial side.
Yeah, pull karo.
Yes.
Yeah, that's it.
Yes. You can use post disc.
Okay. Yeah. So that's it. And now I need somebody to hold the camera here for me. Okay. Anchor on the outside. So we need an outside image. Just hold this here. Drill. Have you got the outside image?
Yeah.
Okay, so I'm.
You will fix it with civil lock?
Yeah. Yeah. I'll fix it with a peak civil lock and in about 90 degrees of flexion. So I'm using a dedicated tap.
That is. Cameraman, can you show the laser mark there? There are two laser mark over the tab. Yes. I think that's the end on view he is showing.
Okay, anchor. So it's best to use a peak anchor rather than a biocomposite for the tibia hard bone. You can see this. Are you
Yes.
you having
You
the
pass your
outside view?
suture
Okay.
and then put it there.
Yeah. Then the knee is in 90 degrees flexion. Good. That's it. And we just see the scopy image. So you see the root is nicely reduced.
Yes.
You don't want to over tighten it also. So the eyelet tip had gone to the mark. So we are just going to now screw the anchor in. It is soft bone, obviously, as we know. Then withdraw it. Yeah, good. Cutter, please.
Yeah. Thank you, Suresh. I think we will go with talk and then demonstration of the lateral meniscus session by Dr.
Perfect. So
Bhupesh.
this is the end result
Yeah.
of the root.
Fantastic. Excellent. You can see the whole of the root has cinched inside and it's sitting there in the crater. Thank you.
Yeah.
Thank you, Suresh.